Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, the director of Speaking of Women's Health, and I am back in the Sunflower House for a new podcast here in season 4 with a colleague, Dr. Laura Lipold. And let me tell you a little bit about her. Several years ago, she wrote this great column on Speaking of Women's Health about when should you see your primary physician versus when do you need to see a women's health specialist. So that's what we're going to talk about. But she's actually bridged both worlds in a lot of respects. She practices as a primary care physician at the Cleveland Clinic, and she's got academic appointments. She went to Albany Medical School, and then she came to the Cleveland area and did her family medicine residency at Case Western Reserve University in Cleveland. And then she went on and did a 1-year fellowship in women's health at Case and also the VA. And she's been on staff for several years. Her primary care practice is closed. Sorry for those listeners out there. I know so many women are trying to find good primary care physicians in the area. And she's the director of our primary care women's health. So welcome, Dr. Lipold.
Thank you for having me, Holly. It's great to be here.
And you are a mother, and tell us a little bit about yourself personally, things you like to do.
Sure. So I'm originally from Buffalo, New York, and so I moved to the Ohio area, Cleveland, Ohio, for my training back in 1997. I've been in Cleveland ever since. Thought I might be moving on beyond training from Cleveland, but I ended up meeting my husband here, and the rest is history. Really a wonderful community to raise a family and to have a profession, so it's really been wonderful.
Yes, and tell us about your work in the Primary Care Institute, what you do being in charge of women's health.
Yeah, I'm happy to share about that because I know I often get this question. So what do I do as far as my role as medical director for primary care women's health? And the way I like to think of it, I really feel like I am the advocate for raising the bar as far as women's health care quality, experience, and access at the primary care level. So primary care physicians and APPs and physician assistants, I'm going to kind of group that together and call them clinicians. We really are the point of access for women for a lot of healthcare services. And so I really like to think that we can really optimize that experience and that quality of care through the work that I do.
Well, that is just absolutely terrific. And it was very helpful when you wrote that column on Speaking of Women's Health about when you should see your primary care physician, when you should see a specialist or a subspecialist even. I know in terms of menopause credentialed experts in the country, there's probably only about 1,000. And we have millions of women that are in midlife and thousands of women who cross through menopause every day. And then, a large group of much older women. And I was just talking to a colleague about how we see sometimes older women and they're told by their gynecologist, oh, you're over 65, you don't need a PAP. And that's not true. You have had a hysterectomy, so you don't even need gynecologic exams, which of course is not true because a lot of women do access their women's health through their gynecologist or sometimes through a nurse practitioner, and some don't see OB-GYN anymore if they're not having children, and they see their primary care physician, and some primary care physicians, like yourself, are comfortable and do, complete exams, breast and pelvic, etc., but then others are not. So do you want to speak to that?
Right, yeah, and certainly I agree that menopause and hormone therapy is a highly neglected area of training and education for primary care physicians historically. I think it's getting better. That's a whole nother separate topic for conversation. But the downstream consequence of that is a lot of primary care physicians may not feel comfortable with maybe providing that care altogether. So again, some physicians have more of an expanded scope of women's healthcare services at the primary care level. Some it might be more basic, some it may not be much at all. So I know that can be really difficult to navigate. And I'm trying to even that out a little bit and really try to provide a lot of education services to our providers around this gap area. But I think the important thing is that that having a relationship with your primary care physician, somebody that you have that continuity with, somebody who you can develop a relationship is really important, because I think either way, what that primary care clinician can do for you is help you navigate a lot of these important healthcare needs as you transition across a life cycle, right? So there are going to be different care needs as maybe an adolescent female, and then you get into more of your reproductive years, and then you move into perimenopause and menopause and postmenopausal and then elderly years. So, I mean, there are kind of a lot of different care needs, and I think the primary care team can help you to transition to that. And then it also gives you an opportunity, maybe better understand and feel what your primary care provider is comfortable as far as care services that they provide. So you might have somebody that very easily can do your pap test, can order your mammograms, will manage your osteoporosis, and feel comfortable with your hormone therapy. There may be others where they say, well, you know what, this is just not my level of training comfort level, and then you may need to partner more with a gynecologist. So this is for, in my opinion, basic women's health care. We are not consultants. And then there are patients who have complex care needs when it comes to their women's health care. And that's where somebody like you, Holly, comes into play. So you are not somebody who's providing, kind of bread and butter women's health care. You are providing care at a consultation level. You have a level of expertise to help guide us in those more complex cases when it comes to menopause, hormone therapy, prescribing, severe osteoporosis, etc. So that's kind of the way that I see the main differences altogether.
It seems like, so we're both old enough that we lived through, July of 2002 when the Women's Health Initiative just splashed onto the newspapers. And I think that was kind of the time period that people looked online and looked to the media for health advice. I mean, it was really quite a time. It was a very scientific study, but unscientifically interpreted, and a lot of people just threw the baby out with the bathwater and threw the menopausal hot flashing women out too, into the hot sauna maybe with their flashes. And so it was a really very disruptive time, and I think a lot of training programs in family medicine, in internal medicine, in OB-GYN just stopped even teaching about menopause and perimenopause. So I think that's one reason we find ourselves in the crisis that we're in. And so that's great. And kudos for you for educating primary care clinicians to feel able to deal with some of the basic stuff and advise their patients and help direct them like they do in many other issues with many other medical conditions. And I think looking at the life cycle, the age, the values, the needs of what that person wants, whether they want or need another women's health person, like a gynecologist in their care plan. And of course, some people have lots of folks and some don't. But one thing that I've noticed, practicing this long, is that it seems like the women that I'm seeing now are actually, many of them, not getting primary care, not getting follow-up on their issues. Even if they see a gynecologist, sometimes they're not even getting gynecologic care, in that this, spacing out of the PAPs. I see women who haven't even had a PAP in 8 years, and they just thought they didn't have to. Before, women were like trained, you got to come in every year and get the exam and get the PAP. And we've had prior podcasts on cervical cancer screening and other types of female cancer screenings. We've had this explosion of metabolic syndrome and obesity, and of course there's increasing demands. I read the other day that 1 in 8 Americans are on injectable weight loss medicines. So that's a lot. And so I'm sure that's a big demand that people are coming into the practice with. So any advice to patients? Because it's great that, on the physician side, you're, having CME courses, and you're doing mini trainings, and you're having lectures for the Cleveland Clinic. But we're in 100 countries, and we have healthcare people listening to this podcast. And we have people who aren't obviously in this Northeast Ohio area. Do you have some advice that you can give to the individual patient themselves, the woman, or actually, we have some men who listen too.
Yeah. Mm-hmm.
How can they prepare better for their visits with primary care? Because I just see patients, when I ask them, when's the last time you saw your primary care? Oh, it's like a year and a half. Mm-hmm. And I'm like, well, you can't go into a visit, especially with an employed physician that's not in direct primary care or concierge care, with a long list of 12 different things in your past due for your health maintenance. And so I think some of the responsibility needs to come, to the person themselves. Mm-hmm. And I wonder if you have some advice for preparing.
Yeah, no, I think that's a really great question. And you really got to the main issue there, the core of it, the heart of it, is that there's just so much information out there, misinformation. Some of it may be correct, but really difficult to navigate all of that. We've gone, and I'm with you. When I was in training in the 90s, we prescribed a lot of hormone therapy, and then the pendulum swung 180 degrees with the Women's Health Initiative, and it really left a lot of primary care physicians in limbo. This doesn't make sense. We just had a very different experience with the studies leading up to the Women's Health Initiative that just really seemed strikingly different in terms of expected outcomes. And it left us in limbo because we were being told you can't prescribe, right? And then, as you said, the other consequences were then the training programs may have been backing away. I'm not, family medicine, I think they really kept up with that, but I'm not really sure with an internal medicine.
Yeah, but, medicine, no. And GYN, no either.
Yeah. And so it was a really difficult time period. And then, thanks to the New York Times article, I think that really sparked things 3 or 4 years ago. Now we've done another 180. So a lot of people are very interested in hormone therapy, but the source of information is very different. So my advice is to patients, when you come in, please come in with your list of questions and really allow your primary care clinician to be a source of truth. So sometimes I just have patients that seek care haven't even seen me and are going to providers that are not practicing evidence-based medicine, that are coming in with, in my opinion, dangerous hormone therapy regimens that have been
pellets,
pellets,
crazy stuff.
That have been concocted based on they said this person ordered like 100 different tests, and so it's really, and then we're working backwards, right? So that's a really difficult situation. So again, allow your primary care clinician to be your trusted source of healthcare. Come in with your questions. They can really direct you as far as reputable places to get more information about the changes that your body are going through, about the perimenopause transition and menopause altogether. So that would be my first suggestion. And you know what, we do a lot of services for you. We really, above and beyond making sure that you're up to date with your screening services for cancers, we do a lot of chronic disease management. We can really help you navigate the healthcare system too as well. We can really be that, gateway to get you into the correct person at the right time based on whatever your specialized care needs are. We deal with a lot of obesity management. We do certainly manage a lot of behavioral health issues. So we can be that one-stop shop for a lot of your care needs.
So that's great. I think for people who can develop a really great relationship with the primary care physician to guide them, that they trust, and who that physician knows who the experts in a whole myriad, area is. I've done prior podcasts on concierge medicine and direct primary care, because I think that's been a big growth in the last several years, and I wondered if you had any comments on that. I mean, of course, you and I were both employed physicians, and and most physicians in the past were in their own practice,
Right.
And now it's almost all entirely employed corporate practices, and now we've seen this kind of pushback, and especially with primary care physicians in demand to go into direct primary care or concierge care.
So for and that's really, I think, an individualized, personalized decision. I certainly see with concierge medicine that for some individuals the payment, the cost up front is for them worth the benefit of having that level of access to a personalized physician. So, so again, I feel like it plays a role for, certainly individuals in the U.S. healthcare system, which is so complex and broken, that, there's a niche for it, right? There's a demand, and there's going to be, there are going to be some individuals that are going to be served very well by that model of care. And I think you might have mentioned like executive healthcare services. Again, that is something that is certainly, I think, a benefit that some individuals may have with their employer. It's certainly something they can take advantage of. It gives them great access, I'm sure, to some wonderful healthcare systems like Cleveland Clinic. I don't think it replaces a primary care physician, just because, again, acute care needs come up, chronic care needs to be managed, and I don't think it's really a model of care that allows for that. So that would still have to be, you would still have to have a primary care physician with that too as well.
And you have been listening to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and in the Sunflower House with us is guest Dr. Laura Lipold, who is a primary care board-certified family physician with academic appointments at CASE and the Cleveland Clinic Lerner College of Medicine. And she actually did a one-year fellowship in Cleveland. And of course, I've been directing our fellowship for specialized women's health, which is 2 years. For, over 29 years. I think I had just delivered my third son and was carrying him in while he was breastfeeding and needing to be changed. And I couldn't even hardly sit down because I had a postpartum UTI. And Dr. Fischleder was right there saying, "You've got to start a fellowship." I'm sitting around a table of men with my third son. So I dramatically remember that. And my goal has always been to train physician leaders who can provide consultative specialty care of these complex patients. Like, I have patients in my practice with organ transplants and breast cancer survivors and cancer previvors, because we have a big genomics institute. And I see a lot of women who've had cardiovascular events, heart attacks, strokes, dissections, complicated histories, very active rheumatic disease and blood clots. And so those patients, which have such a high burden of disease, you would not expect the average OB-GYN or nurse practitioner or a busy family medicine doctor who's seeing patients of all ages and all genders with, many times chronic diseases and needs for health maintenance and behavioral health and metabolic and obesity health, like you mentioned. So a lot of this can be regional too. I've seen this big proliferation. I wonder what you think about online care. I mean, it certainly started, you see the ads in women's health and men's health, and some of it seems focused on hair loss or impotence in men or hormones or cosmesis in women. So we have been speaking with family medicine expert Dr. Laura Lipold, and I was talking about this proliferation of online medical care. We've seen it with advertisements about, for men, if you have hair loss or sexual dysfunction, which of course men can have many other issues besides that. And we've seen it in women, and it's really kind of hit the ground going in terms of hormone therapy, because back in 2025, after many of us working very hard to have the FDA lift some of the box warnings off of things that we don't think should have been on, like warnings of cancer on vaginal estrogen, which those box warnings have been lifted off of, and lifting off the boxed warnings that imply that menopausal hormone therapy is going to increase death rates of heart disease and cancer, which, if anything, the research shows in appropriate patients at the right stage of life, it actually prolongs life. So now we've had this complete flooding of so many people's offices, OB-GYNs, family medicine doctors, endocrinologists, dermatologists. You know, people are asking for facial estrogen cream, which for those of you listeners who want to hear some of the stuff on how to improve your appearance with aesthetics with cosmetic dermatologists, we have several of those podcasts. But I assure you, if you're going to be using hormones, they're very potent substances, and you really want someone who knows what they're doing. That can be a primary care doctor. It can be an OB-GYN doctor, and sometimes it may need to be with a consultative referral specialist in complex women's healthcare, such as myself. And so I wondered what you thought about this proliferation of all this online care.
So there are probably a couple of different models when it comes to the online care. So if you're talking about direct primary care, there could be a niche for that. So there could be the convenience factor, and it could be very affordable for some people who don't otherwise have insurance. So they would pay a certain fee. They would get access to primary care providers that would include some online access. And it would be very convenient for them. So they would be able to access care in a convenient modality at a convenient time. And I can see how this might be attractive to notably maybe, generations that really love their devices and love convenience of care.
You're talking about the Gen Zers?
Yeah, maybe. Yeah.
And millennials?
But I also do have some 80-year-olds that are probably more tech savvy than I am. So, but the caveat there is that it should be with licensed providers. If it is, there are some opportunities with these direct medical care practices where you do develop that continuity of care. But there are some where if there's just that convenience of getting online quickly with a provider who's providing more of that acute care access, there's really not going to be the benefit of any continuity of care. And then when you think about other online care models, you do worry on the back end, what are they licensed providers? What is their training? What pharmacies are they dealing with, right? Is any of this really trustworthy? And that I do worry about altogether. So a couple of different pros and cons when you're talking about different types of online care that people might be seeking.
Exactly. I mean, I was a, quote, digital leader well before COVID because I started offering virtual visits. Because after I had seen and evaluated a patient in person and they were stable, even though I always tried to take the care back to the referring physician or the local OB-GYN or the internist or the family medicine doctor or the APP, whoever they're seeing for their general care, and women couldn't get prescriptions. Now, I think that's going to be less of a problem now that finally, we've righted a lot of the wrongs of the media misinformation and the negative hype about hormones. But that's why I started that. But it was for very specific reasons. And I think that, the dermatologists have some funny stories about doing virtual visits when the patients want to show them the rash and they're bending over and falling over sometimes. You cannot do a physical exam. You cannot put a speculum in, look at the vagina and cervix, get that pap and HPV. There are limitations. You can't do palpation. I mean, you can tell things about a person's mentation and their socialization and their background in terms of where they're, doing their virtual visit from. But I do think there's some serious limitations. And I think it was done way too much during the pandemic. And there was a lot of things that weren't done correctly then. And we're kind of coming out of that. But people do want convenience. I just had a virtual visit myself as a patient. And the physician had to call me because they said, it's set up that you're the physician and I'm the patient. I don't know why that is. I am a physician, but I was being the patient then. And so there can be a lot of technical problems.
Right.
But people can be sick and it be off hours or that. So what percent of your practice, and would you say the average primary care physician in the Primary Care Institute does in person versus virtual?
Yeah, that's a really good question. I probably am a little bit more traditional in that I really like to bring my patients into the office. Less than 5% of my visits are virtual, but I do make them available if a patient feels like that is appropriate. But to your point, I feel like the onus is going to be on the physician and the schedulers and other care providers to make sure the patient is appropriate for that telehealth or virtual visit. Because you're right, there are some, for example, if I'm concerned about pneumonia, I'm not examining that patient with a virtual visit. And my office knows very well, why did you offer them a virtual visit? They need to be in person. So I really feel like the onus is really also going to be on the provider and the care team to make sure that they are, again, getting in with the right person through the right venue at the right time.
And also, acute medical problems, shortness of breath, chest pain, bleeding, like you don't send electronic messages or text messages or ask for phone visits or virtual visits. I mean, that's really important. If your life is in danger, you actually need to get to an emergency facility, and that does need to be emphasized. Just like we're not giving out medical advice here, we are just giving education, a little edutainment, and we're just wanting to empower our patients to be strong, be healthy, and be in charge. I was just having this interesting conversation with a physician colleague just about some care experiences of, family members and other people close to me had. And I was musing, if we can have difficulties when we are insiders and we know the system, I sometimes can't even imagine how it is for patients that are not medically savvy. They may be very savvy in lots of other things. I always like to talk about my husband, very intelligent man, but his medical IQ and lingo is really not there. And I've had patients who tell me that, like when I'm asking a medical history, I just was doing that today. And my patient said, I don't really know any of that medical lingo. I know my mom has problems, but I really don't know what they are. My two sisters who are nurses, they do, and they talk that language. But it's almost like sometimes being in a foreign country and not speaking the language.
Correct.
And so advice like patient advocates or preparing for the visit or letting people know up front what you think your knowledge and awareness is.
Right. That's a really good question. And I think health literacy is something new that we're trying to better recognize, identify, and to meet the needs of the patients, right? Kind of meet them where they are. Your question is very interesting because I know how to answer the question when it comes up with medical students and trainees. How do I assess for health literacy? You can ask the question, do you ever need help reading any healthcare materials that you take away from your doctor's office or information you get from the pharmacy?
So, your recommendations about navigating, through the complex healthcare and having perhaps a navigator or a friend or an advocate with you is helpful.
Right.
Do you ever have patients ask you if they can tape what you're saying, or do you tape and use AI, or do people bring AI into their visits with you?
Yeah, I do. When we started using AI, there have certainly been scenarios where I always ask permission, are you okay if I pull this up to make sure I don't miss anything? They're like, yeah, do you mind if I record at my end? I'm like, no, that's great. So we kind of laugh about it. So no, I have no problems with that. And I actually think it's a helpful tool for some patients. And again, if you're feeling like you're at times maybe not always grasping everything, having a companion with you could also be helpful, just to have that additional set of ears. And then always asking for written information or something in my chart is another way too as well.
Yes, and the electronic medical record can also have things printed in other languages because, of course, we see people from around the world. Right. So that is interesting. I'm pretty much a stickler. I really emphasize that my patients keep hard copy records of important things because it's amazing. I was talking to an orthopedic surgeon who said that they can sometimes take up to an hour when they're seeing a patient who might need revision surgery of an implant or a device orthopedically, but the patient doesn't have the records of what exactly was done and what models and what screws and all that technicality. And, people have pacemakers and implants of lenses and implants of devices for chronic pain stimulation. So I think anything that's really critical, we rely so much on technology. We talked about how people that are tech savvy many times would prefer a virtual visit just quickly on their phone as opposed to in person. And sometimes that is appropriate. Of course, sometimes that's not. But I just think any critical biopsies, because a lot of healthcare institutions don't even have to keep records after so many years. And I have women who can't get their results of why they had a hysterectomy or even what part of organs they had removed. So I think keeping a file of really critical things is good. And if you are on the medical record, even if you think the medical records talk between institutions, sometimes they do, sometimes they don't. We have cyber attacks. Looking at your entire visit, not just the after visit summary, which is maybe directed for patients, but even the clinical notes, because I'll have patients who really read through things and then they'll send me a message. Actually, this isn't exactly right. This is when I was diagnosed, or no, I don't have that symptom anymore. So I like it when patients are engaged in their care. I don't like it when people want everything off their records because they think it's a personal insult that they have a medical issue. I mean, we need medical diagnoses, even screening for breast cancer, to order a mammogram, as an example. Like, you need these codes. I even sometimes have medical people say, take that off my problem list. I'm like, no, you don't understand. I need this to make associations for orders.
And I also make the point that it's important as a means of communication to other members on your healthcare team. So it's critical to have this as a means of communication.
I was giving advice to a friend who's not a patient, but who is a patient, who's not my patient, but is not medical. And they assumed that the doctor they were seeing were going to know about their prior history of trouble with substances. And I said, there's so many places to look in the record. And so that if you know that you can't receive certain pain medicines or numbing medicines or benzodiazepines or whatever, for procedures or diagnoses or evaluation, you kind of need to be upfront with that, because even if things are in the record, as one of my spunky nurse practitioners loves to say, there's 1,000 different places to look. We could be here for 8 hours if you want me to look at every little section of your medical record. So that's something I think that on the other end, people don't always know. Getting back to our discussion about, primary care and concierge care, when I was having this discussion about how difficult it is that our system is so complex, and it's good to have an advocate. It's good to have a good relationship with a primary care person in order to help guide you, through the complex maze and who you might need to see or who you maybe don't need to see, that they can take over that care. With the rage of cash pay, online pay, direct primary care, online. I guess Amazon's getting into the business. Like, so many people are getting into the business of healthcare. One thought that I had, because as a physician, certainly when I'm being seen as a patient, people know I'm a physician, or when I'm going with my family member, or when my kids were little, and I, of course, wasn't a pediatrician, I really appreciated when I was able to say what I thought needed to be done, but then there was appropriate, respectful pushback. Like, my son, I didn't think he had a positive PPD, and I'm like, I don't think he has that. And the pediatrician said, well, we're going to do a confirmatory test. And sure enough, he did. And he needed INH, for 6 months. And I'm glad that I didn't just blow it off and say, I think this is a negative test, because it was a little outside the time. I was out of town. I kind of felt guilty. I wasn't there to read a skin test myself. So even though you are medical, and we do have medical people listening, other people have other expertise. And as long as you know what your limits are, but if someone really thinks that something needs to be done, like I had the pediatrician tell me, no, I really think your son needs to go on Accutane. And I'm like, I've heard bad things about that, because I'm not a dermatologist. And I just read the little media clips, and they said, no, this is an effective treatment and your son should be on it. And he was, and it was really good. So if I was paying for a concierge doctor and I said, no, I don't think this needs to be done, or I'm concerned about this therapy, maybe they would back off because it's cash pay. And so I think that there is pros and cons, but I see so many women who come to me and they've seen a physician and they said, well, my doctor says they don't feel comfortable, giving me this therapy. And I think that's kind of ironic and a little inappropriate to say, because our comfort as the caregiver and the physician, we're there, of course, to take care of the patient and how they feel. And so I think that if they say, I think this treatment is too risky for you, or I don't know enough about the other options, and because I feel that you're at higher risk and this may not be the best therapy, then let's bring someone else into the care. I think that's a better way of dealing with it. Because I have patients, and I'm thinking of one of my patients who's been through a lot of different things, and the treatment she was asking for me was not standard and is higher risk than other things, but she tried those other things and she's like, I'm willing to do this. And I understand that it's not standard and that it's riskier. And so I documented that. I said, yeah, it's not really standard, but I understand you're very different and unusual, and you've already been through so much that I'm happy to prescribe this for you because I want to take care of you and you understand that it's not standard. But it would probably be best if I see you sooner and we monitor you a little closer. Right. And so I think that kind of relationship is better. And I know I personally had that experience myself when I found something that worked, and it's cheap kind of therapy. And I'm like, I know it's not really standard of care, probably because no pharmaceutical company can make money off of it to patent it. But I kind of maybe like to consider this as chronic treatment. And the response back I got was, well, I don't feel comfortable with this. I'm like, well, it's not your comfort level. I'm the one having the symptom. And so I'm like, it is a give and a take. And I think that, everybody kind of needs to be upfront with their expertise, certainly in issues of, substances of abuse. Obviously, you're in pain, and for chronic pain, sometimes, there's a whole issue of addiction and substance issues. And there's been that whole pendulum. Doctors gave too much because they were being judged on if the patient was happy with their experience. I mean, there's sometimes people I know aren't that happy with their experience with me because they don't want to hear what I have to say. And I think sometimes that's really what's best for them. On the other hand, we've seen this, people with chronic pain and cancer pain, and because of the opiate epidemic, there's been all these restrictions on physicians. I wonder if you wanted to comment on that as a primary care physician for your patients seeking pain medicines and seeking pain relief.
I do just want to comment on what you said around patient-centric shared decision-making, right? And I think that the key thing that you said was the patient was alluding to the patient making that informed decision. So as long as the patient fully understands the risk and the benefits, and again, the onus is on us to make sure that they're making a fully informed decision. We have to make sure we're providing them with that necessary education in order to make the decision. So I agree with you. I think that's a really important piece of the care that we provide. Regarding the opioid epidemic, I will tell you that this is maybe the one circumstance where there's been a positive downstream effect of the media and the opioid crisis. I think nowadays everybody knows somebody who's been touched by a heroin death or an opioid overdose, right?
Yes.
Absolutely.
It's terrible.
So usually the conversations, we tend to just, at least myself, and I think a lot of my colleagues practice this way too as well, as we're getting into pain management, we do the first line things. And if we're starting to have the conversation about, they're at a level of pain with what's working, what's not working, we engage early in that discussion about these are the real risks with opioid based medications. And the patients often, as soon as you start to bring up I don't want that, just so starting to have that conversation early on in their pain management treatment plan, I think can be very, very helpful. And I often see that really most of my patients are like, I don't really want that. That's not really something I want to do. And we often can find a lot of other tools to help manage their pain. And we've learned so much about pain management, especially as a result of the opioid crisis. So,
and we have an excellent pain management department, and there are so many modalities, and we've had podcasts on, acupuncture and functional medicine. And sometimes even if you have a physician who's giving you a prescription, I'm thinking about a colleague whose partner had severe pain, and they had to come in every 4 weeks to get the medicine, and because of all the restrictions, and they were just complaining about that. And I thought, maybe it's time to take a look at a second opinion. And she said, like, well, our insurance doesn't cover it. And I'm like, yeah, I know. And you've just gone overseas on a trip. I think you can afford cash pay. Went out to a different physician. It was only a few $100s. Got the actual real diagnosis. Was told what needed to be done, which was a surgical procedure. Now it's not on chronic pain. Right. So I think I've seen people who need pain medicines and that, they're denied, and you've read stories about people killing themselves because they had chronic pain and they couldn't take it anymore. We've talked on the podcast about ketamine and with different physicians, and that has provided relief for some of my patients with chronic pain. On the other hand, read about prominent cases of people overdosing on it. So it is really tricky. And I think having a trusted primary care physician to help guide you, push back maybe instead of just giving you this, you need to do that. On the other hand, you have done everything, and, you're going to work with me and maybe sign a contract or be willing to accept what these risks are, and then we'll do that. And so it's been really such a great discussion talking with you about all these nuances and all the changes in the field and helping people navigate through this. Any resources or online sources or ways people can contact you or your colleagues if they're, in the Northeast Ohio area and looking for a primary care physician?
So I really think the Cleveland Clinic website has improved as far as
it's
providing.
It's still hard trying to find someone, I think.
Yeah, but that can always be helpful. As far as we do have a call center too as well if you're looking to get access to care. So I think that's always something. And then you can certainly talk to your trusted friends and colleagues to see if they have a recommendation by word of mouth, because often it can just seem overwhelming if if your insurance company gives you a list of a name of primary care providers, like, who do I go to? So
clevelandclinic.org. And then, of course, I always recommend our website, nonprofit, speakingofwomenshealth.com, for women's health related information. But we have some other information just on general health too, not only exclusively women's health, but mainly. Well, thank you so much, Dr. Lipold, for joining us in the Sunflower House. To our listeners, thanks for tuning in. If you enjoyed this, give us a 5-star rating, and you can share this podcast. We're on Apple Podcasts, Spotify, Amazon Music, Podbeam, wherever you catch podcasts. We're on YouTube and Rumble, and we have some clips on Instagram. So thanks for joining us, and remember, be strong, be healthy, and be in charge.
Thank you, Dr. Thacker.
Thank you.